So look, just this is a summary slide so that if you want to go to sleep after this, it's all stuck in this. So the main differences this year for the vaccine is introducing HPV-9 to boys and girls, and you guys will be pleased to know that we have run out of HPV-4 in the country, and so if you ask for your next supplies, you will get 9. It was really cool. I had a chocolate fish on when we'd run out, and I lost. Apparently we ran out a couple of weeks ago, so we've pretty well used up all the supplies of 4, except for those that are in our fridges. The other thing that's going to change, as I think everybody knows, is we'll be introducing varicella vaccine to toddlers on the 1st of July. And then there's a few other essentially brand changes. The rotavirus vaccine is changing to Rotarix, which is the difference from Rotatec's is a 2-dose schedule instead of a 3-dose. And the other issues are also brand changes, that we're changing from PCV13 to BCV10. And in practice, they probably make very little difference. So, you know, the world keeps changing depending on what Pharmac decides to purchase, essentially, with pneumococcal vaccines. And the others are just brand changes, MMR and Hib. So I was just going to touch on HPV first and see if we could answer all the questions we're getting in HPV. So we had a sort of a flurry of questions on our phone line back in January. So I pitched this around what we think are the most common questions with HPV vaccination. So just in case we don't remember what HPV is, it's still extraordinary. Well, it's not extraordinary, it's no surprise that still most of the world is very confused about HPV and what it is. And of course, we're really only focusing on the oncogenic types of HPV, plus 2 low-risk types, 6 and 11, that cause genital warts. The rest of HPV, we're never going to focus on, and vaccines are not going to pay any attention to warts that come for other reasons. So why are we going to 9 serotypes? Why didn't we just stick to 4? Well, essentially, I guess it's because we had the technology to make 9 happen. But this is the main reason, that essentially this vaccine was designed as a cervical cancer vaccine, first and foremost. And most of the world is using it still as a cervical cancer vaccine. And when you look at cervical cancer, HPV-4, the types 16 and 18 in it, cover about 70% of oncogenic types. You add in HPV-9 and we're getting probably another 15 to 20% protection. So it is expected to add a reasonably significant extra amount of protection to HPV from the 4. So the question is, well, why are we giving it to both sexes, is the next question. And my son keeps moaning to me that he's the only boy in the universe that was forced to have a cervical cancer vaccine. Poor lad, you know, it's parental abuse, really. And so why are we giving it to both sexes? Well, there's 2 reasons. The first reason is, of course, it's going to help herd immunity for the girls. But the second reason was that we're offering significant protection to boys, genital warts, plus also other types of HPV cancers that are much more rare, and we would not have made a vaccine for them because they're rare, but they're still pretty significant and they're pretty nasty. So while this is a cervical cancer vaccine, the more we look at HPV, the more we discover oncogenic HPV is actually implicated in nearly 2/3 of penis cancer, more than 70% of vulval and vaginal cancers, more than 90% of anal cancers, and more than 70% of oropharyngeal. And I mean, it's extraordinary that oropharyngeal cancers in particular are on the increase in New Zealand. And oropharyngeal cancers that are traditionally related to smoking and other factors like alcohol are actually not on the increase. It's HPV-related oropharyngeal cancers that are on the increase, particularly in men. And we don't need to think too hard about sexual practices to wonder about that one. Yeah. So this is why we're adding in 9/7. So if you look at the red bars, these are what type 4 is expected to cover, so traditional Gardasil. And if you see the green bars, you can see that you get a small amount of extra gain by using HPV-9. So it's not huge, it's just a small amount of extra gain, but it's there, and we've got the vaccine and it's been given to us, so you know it's definitely offering some benefit, but I wouldn't overpromise it about being hugely significantly more gain over HPV-4. But you can see that there's a particular gain for cervical and probably vaginal, and probably smaller gains for some of the others. So, you know, the first argument is why are we offering it to boys and girls, was that there was a lot of discussion around cervical cancer that if you get herd immunity, you will get better reductions. Now, we could have got herd immunity by getting high rates in girls, but it would leave out an important, significant group of men who have sex with men, who would not be protected by herd immunity. So then we went down the track of, well, could you offer a vaccine to young men who in the future will consider becoming MSM? And it got extremely complicated, as you can imagine, when you started going down the, hey, GPs out there, you guys are going to offer a vaccine to 12-year-olds only who may become MSM. So at that point we went, no way, this is impossible. You know, universal approaches are so much easier. So thankfully, New Zealand's one of the earliest countries in the world to be able to offer the vaccine both to boys and girls. And along the way, we got HPV 9 rather than 4. So the question, I've got a couple of slides on whether the vaccine's safe. The bottom line is HPV vaccine has a fantastic safety profile. HPV 4, it's got a brilliant safety profile. Academically, the research world is not worried about the safety profile of the vaccine. The problem with this vaccine is being done by social media. And if any of you want to tiptoe and have a look at the social media, there's a whole lot of myths out there that are floating around about this vaccine. Just before I come to those myths, I wanted to say that most of the safety data is around HPV 4. Is there any difference for Gardasil 9? Probably very little, except there's more aluminium in it. So it's got more aluminium in the adjuvant. So that means you're likely to get increased sore arms and local reactions. So the real difference from 4 to 9 is likely to be increased local reactogenicity. Other than that, it's not likely to act in any different way from HPV 4. I think the safety problem with HPV vaccines, I actually think comes down to giving things to teenagers. So teenagers, as we all know, things go wrong for teenagers. If we vaccinate a lot of teenagers, things will happen. And the vaccines are getting blamed for some interesting, unusual, complex issues out there. So one of the problems is you start talking about the myths, people associate it in their mind as if there is an association. And all I want to say at this point is there's a lot of myths out there. There's this thing called positional orthostatic tachycardia, there's complex regional pain syndrome. They're affecting the uptake of this vaccine in a few countries in the world, and we cannot see any association every time we look at the science. So I don't want to create myths. I want to say that this vaccine's got an excellent safety profile. Now, I'll finish what I'm going to say about HPV and we'll see if there's any comments. So is it effective? Well, the answer is, of course, we don't know yet. It's going to take us a long time to start seeing diving rates of cervical cancer and other cancer. But the early data is really promising. I think most interestingly, that the Australians think now that they might actually be able to eradicate genital warts. They're getting remarkable results of reduction in genital warts. And there's a lot of results about the early signs of cancer, like precursors to cancer. So to date, it's looking really promising. Time will tell how effective this vaccine will be. And does it last? Well, at this stage, we've got 10, 11 years data showing that there's no sign of waning immunity. Now, we don't know in the future whether there will be waning immunity in 20 or 30 years' time, but at this stage, it's looking very promising. So the worst case scenario would be we'd have to turn around and say you need a booster, but at this stage, it's looking like this vaccine's expected to have very long-lasting immunity. Why don't we wait? Why are we giving the vaccine so young? You know, so you get a lot of people coming in and saying, look, I know my daughter. I completely trust my daughter. She's not going to have sex till she's 45 at least. That's what I believe for my kids, eh? Well, you know, you can say to the parents, yep, that's fine, no problem at all, but there is actually a compelling reason to give this vaccine earlier, and we don't even need to discuss sex. What we know now is immunogenicity is better if you give it young. So, you know, it's all downhill for the immune system when you get to my age. You know, start younger, the immunogenicity is better. So what we've switched to this year, knowing that younger people get a more vigorous immune response, is if you get 2 doses before you're 15, that's enough. You don't need a 3-dose course, you only need a 2-dose course. So now we can say to everybody, give it earlier because you'll get a more vigorous immune response. So we don't need to worry about the onset of sexual activity. What we want to do is give the vaccine earlier and you'll get a better, probably more prolonged immune response. So that's very useful. So now the schedule is 2 doses, at least 6 months apart, for anybody under 15. If you get your 2nd dose 15 years or older, you're going to need a 3rd dose. So a good reason to try and encourage them to come in earlier. Okay, I just had a few other questions up here. I'm already sexually active. Is there any benefit to the vaccine? Well, the answer is has this person been exposed to all 4 types, now all 9 types, and had an immune response? We don't know. So while there's likely to be decreasing gains the more sexually active somebody is, there probably still are some gains, because most of us will not have been exposed to all 9 types and had an immune response. So the answer is, if you could give it, why not? It's a good vaccine, it's highly safe, it's effective, so it's worth it even if somebody's sexually active. People who are outside the licensure range, we don't have any data beyond the age of 45, but there's no reason to suspect this vaccine wouldn't be safe over 45. Once again, the older we get, it's probably slightly less effective, but there's no reason to be concerned about a safety profile for an older woman. We've talked about 2 doses, not 3 doses, and we've talked about the fact that there's a lot of social media talk about this vaccine. And I think, so that's a bit of backup data for people when they're asked. And I think my final comment on HPV is, we've still not got particularly high immunisation coverage for this vaccine. There's a whole lot of myths floating around, which is part of it. But one of the biggest issues is that it's not recommended by us. So people are coming into the general practice. Now, I may think vaccines are the best thing since sliced cheese, but most of us get distracted and think about other issues. So remembering now that all our teenagers, from aged 11 through to 26 are entitled to free HPV vaccine. That's quite a big part of our general practice, and for us to remember and put it in our systems so it's in our face to remember to offer this vaccine to people. I think it's a bit challenging. We've been asked to recall everybody up to the age of 26. I think for many of us, it's a bit of a tall order. But I think if we can at least look at our systems within our practice and at least flag and note everybody up to the age of 26, and particularly a lot of the boys who would not have been offered this vaccine at all. So now we know it's available and it's free, and we should be offering it to everybody. Your first dose to be free needs to start at 26, and you can have the second and third doses later, and it's still free. So that was most of my comments on HPV. Does people want to ask any questions or comments about HPV? Yeah, down the front here. Yeah, so would you benefit from having the vaccine after colposcopy? There was one early study that suggested you did. There's been a meta-analysis that suggests the benefit is probably not there or very small. Having said that, for an individual woman, you don't know the answer to that. You don't know if she's been infected with all 9 types and has responded. So if she's under 26, you'll get it for free, give it. If she's over 26, then it's a matter of whether they can really afford it. And we can't figure out the gain for any individual. It's a bit of a guessing game how many HPV types they've been exposed to. Clearly it's not going to work for the types you're already exposed to and had an immune response to. So, any other comments about HPV?
If there are questions, could people use the microphones at the front so that everybody can hear the question? Thank you. Or there is a roving microphone, is there? Yep.
Yeah.
So if we wait for the roving mic, that'll be great.
12,
Yes.
and so I've just signed the consent form, obviously, for him to have his HPV vaccine. But I was just surprised at the lack of information that came out with the consent form from the school, and I'm also surprised by the number of parents who are opting out of it because of poor information, and I just wonder whether or not that's being looked at. Because people are offered it through the school system, so they're not necessarily coming to the GP to find out more about it.
Yeah, the lack of information is really because the ministry had what I would consider a very inadequate resources to introduce and promote this vaccine. So you'll see there's been a bit of advertising around, but it's extremely limited. So I think the answer is the lack of information is a direct result of the lack of resources and funding put into it. So it's quite interesting. We've just introduced to the whole country a new vaccine, and there's very limited information. So I completely support your comments. The other thing is the material is all pitched at 12-year-olds. So if you've got older kids, there's no material, promotional information around young adults and older teenagers, completely different group. So it comes back to us in general practice, and there's really no resources for us. We're just told, yes, please go out and, call all these people in for their HPV vaccines. It's quite a big ask. So, I think it is a limitation in the system.
And just the vaccines that are given at schools, we don't necessarily know if they've had them or not. It doesn't, we then have to phone up the Central Immunisation Board to find out, which is another phone call, another little bit more time. So we're not just opportunistically bringing it up in a consultation. There's a little bit of groundwork that's got to go into that.
The school-based vaccination system is meant to be informing the GPs, but it's only as good as them knowing who the GPs are, so it's not working well. I absolutely agree, it's not working well. So, one of the things I often suggest is, if you don't know, assume they're not vaccinated. It's so much easier than spending hours and hours and hours trying to figure out. So, I think it's easier to send carefully worded recalls out saying, if you haven't received the vaccine, it's available for free. Because there is still quite a big gap in the system there, I agree. There was a question over here.
Yeah, I don't have a lot to do with the vaccinations myself. My staff do, but I just wondered in that age group whether are there any apps that are being used, since kids that age are very much into social media and also using apps, and I just wondered if they're an age that they could potentially look at it themselves and consider it.
Yeah, that's correct. I think once again it's the very limited resources that's gone into this campaign. So there's a whole lot of things we want to do and are potentially able to do, and it's not happening at this stage. So for the moment, we're reliant on just embedding this into the routine system. And there has been discussions around apps and social media, and I'd love to see SMS using much more text messaging about following up on safety issues. Once again, the resources are very limited. We've got a cool vaccine that's arrived with very limited resources to support it. Was there another comment down here?
In terms of getting the information to the GPs, often it's the question, the kids or the parents ask, who's your GP? And they go to a clinic and it's a different GP every time. So they should be asked, who's your general practice?
Yes. And we have told them that point and we've repeated it, but they do say on the other side, even when you ask who's your general practice, it doesn't come back. And informed consent forms in school-based programs, as you can imagine, have a lot of challenges. And I think our public health nurses are under a huge amount of resourcing stress. So I don't want to put them under burden at the moment either. So we have a national register. It is all on the register, but as our colleague pointed out, you don't want to go and check every single kid. So my default position is to assume they're unvaccinated. Schools are getting about 60% coverage at the moment, and despite all the social media activity out there, the rates are not diving. So we have to have confidence in this vaccine. I think it's getting a bad rap out there for no very good reason. Yeah. No, I assume they're unvaccinated, sorry. Yeah.
So when you say you assume they're not vaccinated for this, do you then go ahead and vaccinate them?
Oh, yeah, no, I was suggesting with the general practice recall system, when you don't know whether the kids have received it in school-based or not, even though they're meant to be informing us, it's not working well. So at this stage, my best advice to us is if we're not sure, rather than spend hours and hours on checking, ask. And they will remember if they're vaccinated or not. Sometimes they get a bit mixed up with TD, but on the whole, they'll remember. If you accidentally double vaccinate with this sort of vaccine, there's no safety concerns.
Nikki, I don't think you're the only mum whose son, so you can reassure him. But the selling point for me was talking about genital warts and talking about preventing close partners from getting cervical cancer. That's what the boys need to know. They buy that, and also making sure that they know that the injection goes into their bottom and not anywhere else, because my boys had assumed that it might go somewhere else rather than their bottom, and confessed that to me. So they were the three things that I discussed with my boys, and then they were really keen to have it and surprised that their friends weren't able to have it at that time.
That's very useful. I actually focus on genital warts, and the national program has decided not to, and I disagree with them, because I don't think teenagers are particularly worried about elderly cancers. They are worried about sexual transmission, they are worried about warts, and a few pictures of warty willies go a really long way. And yes, so I do believe in the power of the story, and the warty willies are very effective, and actually one carefully shown picture of cancer of the penis is horribly effective. It's amazing how effective that is for a teenager. And yes, the injection's in the arm. You're right, not in other places. So really good points, and yes, I think we need to promote it more, but in the meantime, we're the frontline people with this vaccine, and it genuinely looks like a fantastic vaccine. Very similar vaccine to hepatitis B, acting in the same way, same technology. excellent safety profile. So yeah, it is a bit of a challenge at the moment with our systems, but I hope we get the vaccine out there well. So I'm going to move on quickly to varicella. Now, I think most of us already know the varicella vaccine because we've been using it in primary care. So the real question is, we've been using it, in the private market for a long time. But the real question is, why would we introduce it into the national schedule? Most people will come back and say, look, this is a mild disease, what's the deal? Well, I think the point for us is that pretty well everyone gets chickenpox. And even though for the majority of kids it is a mild disease, there's a significant number of kids for whom it is not a mild disease. Now, obviously, there's a big group of kids who are immunocompromised and they need protection, either if they can get the vaccine themselves or they want herd immunity to protect them. So that's a big and important group of kids. There's a lot of immunocompromised kids now in the community. But the majority of kids who end up in hospital with chickenpox side effects are still healthy, well kids. So when you look at the numbers game, if you just look at a straight numbers game, there's still a lot of kids who end up with problems from chickenpox. And there's a lot of secondary skin infections in New Zealand, and there is a small number, but when a lot of kids get it, there is a small number of neurological conditions, and you do see cerebellar ataxia, and you do see a range of other things. So the answer is yes, for most people it's a mild disease, but for a significant amount of kids in New Zealand, it's more than mild. We're introducing it to the New Zealand schedule on the 1st of July. Why are we only using a single dose, not 2 doses? Well, the answer is that a single dose is highly effective against severe disease. So you will still see a lot of breakthrough disease after a single dose, but you are unlikely to see hospitalised and severe disease after a single dose. So a single dose is adequate to reduce severe disease. If you wanted good control overall, then you really need 2 doses. And in many countries in the world, they start with a single dose, and then while you've still got a lot of circulating varicella, you'll get a lot of wild boosting. And then as you get better control over circulating varicella, they eventually introduce a second dose. So my guess will be we will eventually introduce a second dose. Now, the challenge of a single dose is giving 4 injections to a 15-month-old. Now, my practice nurse colleagues at this point, they just put their hands down and their head in their hands, but actually practice nurses have been doing for many years 4 injections at once at various times. We did a lot of this with the meningococcal B campaign. So a confident practice nurse with a lot of familiarity does manage to do 4 injections at once. But that's really the challenge, is the delivery. Okay? Now, the other quirky issue that's coming up is that, from the 1st of July, it's for every kid who turns 15 months from there onwards, okay? There's no, kids who are older than that do not get it for free. But for any kid who turns 11 from the 1st of July, if they've not already had a dose of the vaccine or they've not already had chickenpox, they're entitled to a single funded dose as well. So that's a little bit confusing for our service delivery. So it's those who turn 11 from the 1st of July. I don't know how we remember this or how we recall it within our systems, but they are entitled to a single free dose if they're not already immune. Now, the other thing I don't think we should forget is that that's the funded, but there's also quite a few groups that are recommended and not funded. And I would say anybody out there in the universe who's an adolescent or an adult who has not had chickenpox, you'd be mad not to have the vaccine. Because as we know, late adolescent, adult chickenpox is a lousy disease with a lot of nasty morbidity. So there's still, I would still counsel us to remember older adolescents and adults who may not have had chickenpox, okay? And interestingly, those who come from tropical countries, they don't see so much chickenpox in tropical countries. So some people may not have had a history of chickenpox as kids. So just remember those. And particularly for us, if there's any GP in the room who's never had chickenpox, and any other high-risk occupations. Does it work? It's highly effective against severe disease, less effective against mild disease, okay? You do see breakthrough varicella, okay? And of course, immunocompromised people, the effectiveness is going to be less clear. Does it work? Yeah. There's been a huge amount of experience with this vaccine. This is not a new vaccine. This has been around internationally since the 1990s. The Americans have huge data on this vaccine. So we've got a lot of data on the effectiveness of this vaccine in programs. I have to say, like 15 years ago when I started in this game, I wasn't that confident about this vaccine because the question was whether it would shift the epidemiology of the disease. So if you vaccinated all your kids, would it wear off and you'd see severe disease later on? Well, the Americans have been vaccinating now since 1995, and what they've seen is a dramatic reduction in varicella across all age groups. They have seen a slight shifting of the age groups. So you are seeing, instead of young kids getting it, you're seeing it slightly older, but the overall reduction is huge. So the answer is we've got good data on the impact of this vaccine in many countries around the world, and the Americans have got the best data. So if you like the visual data, there we go. It works very well. It also has very powerful herd immunity effects. And does it last? Well, the problem is what tends to happen is you get herd immunity effects. So it's hard to know about duration of protection because you end up just reducing the burden of varicella in the whole community. So it does look like it's got at least 10 years data, if not more. And the 2 dose is likely to be even longer. So I will guess that eventually New Zealand will introduce a second dose. Herd immunity is brilliant in this vaccine. It's very effective. Now, just the side effect profile, I think people are familiar with this. It's a live attenuated vaccine, so you cannot give it to severely immunocompromised. I mean, I think if you've got people who are mildly immunocompromised, ask the question about whether they can have it or not. It's a cellular immunity issue, so you think about it. The only other thing to know about vaccine side effects is that if you have this vaccine and you do get breakthrough vaccine disease within 1 to 2 weeks after receiving the vaccine, that is theoretically transmissible. So if you do have an immunocompromised family member, think hard. You cover the rash, keep the child away from the immunocompromised. There's only been a handful of cases internationally where it's transferable, but it is theoretically possible. Okay. And so I mentioned the safety profile, just remember immunocompromised. Right, so the question becomes, I'm not sure if people are aware, but there is a vaccine out there that combines varicella with MMR called MMRV. So why are we using 4 injections instead of using MMRV? Well, the interesting issue is when you combine varicella with MMR, you get an increased instance of reactogenicity, including febrile events. Febrile events at the age of 15 months, febrile convulsions. So when you use MMRV at 15 months, you see more febrile convulsions. So New Zealand made the call to use the separate injections at separate sites rather than run the risk of increased instance of febrile convulsions. So that's why we're not using MMRV, we're using varicella. Now, if we do eventually introduce a second dose, it would be very likely that the second dose can be MMRV, and you don't see the increased instance of febrile events with the second dose. So that's my summary of why that's the situation. Multiple injections, this is really much for the vaccinators out there. And the answer is, it's about the confidence of the vaccinator. So people come back and say, the parents don't want multiple injections. Well, the answer is it's usually from us as the deliverers, not the parents. And that we do know that a confident, well-trained vaccinator with experience can do it and does it well. So we've got our own organisation, NIMAC's got a lot of resources now about how to deliver 4 in a row with some videos and some backup support. Now, if you still get parents that want split vaccines, that don't want 4 at the same time, they want split, the issue is which ones would you give first? And our advice is to give the most important first, and the most important vaccine is always MMR. So we would suggest giving MMR first if the parents don't want 4 injections. And I would normally suggest you give MMR and varicella together because they're both live vaccines. And then if you don't give the live vaccines together at the same time, you need a month's gap. But if you give the MMR and varicella at the same time, the other 2 vaccines you can give at any time interval you like afterwards. Now, this is the other really interesting question. The reason why many European countries in particular didn't introduce varicella earlier was this argument that if you have less circulating varicella, so then you get less wild boosting, then you're going to see more shingles. Well, the data in America to date has shown that that's not happening. And the other issue is it was just a theory that you need to be exposed to chickenpox to boost your immunity to shingles. But actually, there's no evidence of that so far. Quite the opposite, because if that was the case, none of us in general practice would ever get shingles, eh? You know, we'd have so much chickenpox that we should never get shingles. Now, actually, I've seen so many GP colleagues with shingles that I don't think it works. And also, apparently, with the American astronauts, when they fire them into space and they come back, they've seen boosting of their shingles immunity. So I don't think it's anything to do with exposure to chickenpox that boosts or doesn't boost your shingles immunity. So this was a theory that held up many countries introducing varicella programs, and it doesn't seem to be the case. So those are my general questions. I think now, so a lot of people will say, you know, you can have this vaccine from the age of 9 months. Their child's going into early childcare. They would like the vaccine earlier. The answer is yes, of course you can get it on the private market, and you're still entitled to the funded one at 15 months. I think we've discussed 4 injections, and 2, I think we've discussed all those other ones. I think, how do I know if I need the vaccine? So this is for 11-year-olds. We usually take a history of chickenpox as the answer, but if people aren't sure, you can do a blood test, but usually it's not funded, so people have to pay for that. So often it's easier just to go ahead and vaccinate if people aren't sure about the history. So those are all my questions on varicella. Has anyone got any comments about varicella? Questions, issues? Yeah, up there.
So people who will never have chickenpox because of the immunization, they will never have shingles because of the same virus, is it?
So if people are vaccinated, because it's a live attenuated vaccine, you've still got an attenuated virus on board, so you can still get shingles. So it doesn't eradicate shingles, but the incidence of shingles is significantly lower, by 7 or 8 times lower. Okay, so you can still get it, but less likely. Yeah.
Just with the varicella vaccine being funded for over 11s, is that like 11 to 18 or?
No, it's people turning 11 from the 1st of July, and you're correct. From then on, once they turn 18, it no longer becomes funded. So you've got to get it in, you can offer the funded free one up to the age of 18. You know, like the same with the other vaccines, it's funded free up till under 18, yeah. So you've got to count back, so it's kids that are born 11 years earlier from the 1st of July, yeah. It's a complicated one, that one. Any other questions about chickenpox? Yeah.
16 months, they have to wait till they're 11.
That's correct. So kids who are 16 months who have missed out. They have to wait till they're 11. And there's nothing fair in medicine. You introduce something new at a point in time. You're quite correct. So you miss out if you're over 15 months on the 1st of July. It's just the way it is. You introduce something new for the first time and the government decided not to have a catch-up campaign. So it will take us longer also to develop herd immunity because of that. It's going to take us longer. But that's essentially the funding call that they've made the decision. Mm.
Just to clarify, with Zoster, you said it's 7 or 8 times less likely if you've had the vaccine. And do you know, in terms of severity of if you do get shingles,
yeah.
Do you know if the severity is less as well?
The assumption is the severity is expected to be less. The problem is, of course, that you know, the severe zoster is in the elderly, and the American program's only been going since the mid-90s, so we haven't yet seen the effect on elderly zoster. So we're assuming it's likely to be less severe, but we'll just have to watch and wait and see. I mean, in the meantime, of course, you know, many countries are introducing the shingles vaccine. So Australia and the UK have now got the shingles vaccine on their program for 70-year-olds, and New Zealand's in discussion about this. I would also like to say that there is a newer shingles vaccine come along that might even be better than the one current. Now, I was going to just go and talk about a few interesting international bits and pieces, but I was wondering if anyone's got any specific immunisation questions in general you want to ask first, because otherwise I'll just start rattling on about some more interesting, to me, immunisation issues internationally. So any questions? Yeah.
I'd actually just like to hear a bit more about the shingles vaccine.
Shingles vaccine, yeah. So the shingles vaccine is licensed in New Zealand from the age of 50. We know that it's pretty effective. You know, older people, it's hard to get a vaccine that you get a strong immune response to, but it's at least 50% effective against shingles, and more importantly, it's probably about 65, 66% effective against post-herpetic neuralgia, which is the real biggie. So this is an important vaccine for older people. So which age do you give it is a really difficult question, because at the moment it looks like it has got immunity lasting maybe 5 or 7 years, but it does look like it's not going to be long-lasting immunity. So if you give the vaccine at 50, we don't know yet whether you'll need boosting. So when you have to pay a lot of money in the private market at the moment, people keep asking me what age should you give the vaccine. It's a really difficult one to answer. So currently I'd be saying, look, because it's expensive, I wouldn't necessarily personally give it to a 50-year-old unless they've got a whole lot of comorbidity. So I'd probably sort of delay it more like 60 or 65. But that's my personal opinion, because people have to pay for it. You know, it would be a different call if it was on the national schedule, which is why the UK and Australia have decided to introduce it at the age of 70. We don't yet know how long-lasting this vaccine is going to be, and we don't yet know the role of boosters for it. But if you get pharmaceutical companies visiting you, they'll tell you start from 50. Any other questions? Other vaccines? Any other vaccine issues, or I'll just come on? When are BCG vaccines going to become available? There's an international shortage at the moment of BCG vaccines, and it's not likely to improve. So at the moment, we have no idea when the BCG vaccine will become available again. We've got no idea at all. So the problem is, if you want to give BCG vaccine to neonates, you want to give it before they're 6 months of age, or else you have to do a MAN2 test. So we're going to soon have a cohort of children from high-risk countries who have missed out on BCG. So it's actually quite a problematic issue at the moment, is whether New Zealand continues to deliver BCG vaccines when we don't know when the supply will be restored. So all we can say is watch and wait. You know, there's other countries that are higher need than us.
Her father has been diagnosed with TB recently, and she has a newborn child now.
Right, so this
And
is a
she's
woman who's
concerned.
got a newborn child with a father with TB in the family, and we'd like the BCG vaccine for them. We have no supply, so we have no choice, is the answer.
So what will we advise her?
Well, you'll be advising to watch closely. You want to use the other traditional methods of keeping the infant. Presumably the father's being treated, and the infant hasn't been born yet, or about to be born.
Already
Right,
born.
so long as the father's under treatment, then he shouldn't be transferring to the infant, you know. I'd be much more worried if he was undiagnosed and then you discover later. So at least he's already diagnosed, he's already under treatment, so hopefully the infant should be fine. But they need to know we just don't have BCG.
Okay, thanks.
Yeah, behind
Thank
you.
I just want to ask about the MMR vaccine and a woman who got, you know, a negative serology, you know, as an antenatal blood test. So in the handbook, I think it says that the level that they're, you know, saying that those women are now immune to rubella is 10, I think it was.
Yeah.
But it also then says to go with the lab advice, and the lab advice usually, if anything's under 15,
Yes.
it says to vaccinate them.
Yes.
So it gets a bit confusing, particularly when the woman's had 2 documented doses of MMR.
That's right. So serology is an imperfect science, in case anybody thought it was so black and white. So the international guidelines is 10 international units per litre, but different laboratories have slightly different assays, and they make different decisions about thresholds. So the answer is, yeah, go with your lab. Make sure they've had 2 documented doses of MMR. After that, if they have 0 rubella, then they probably never seroconverted. But if they've got some rubella antibodies, but they're lower than 15 or lower than 10, they're highly likely to be protected. And it's just the inadequacies of us knowing exactly what borderline serology means. So I'd say make sure you've got 2 good documented doses. And after that, you know, if it's 0, then the person's not seroconverting. And if you're around 7, 8, 9, 10, you're probably protected. Yeah.
Hi, I'm a GP in Raglan. I just wanted to ask you a question more from a public health perspective about immunisation generally. I'm in an area where it's really hard to get anybody to immunise anyone. And the more vaccines come out, the more difficult that becomes.
Yes.
And I'm just wondering from a public health perspective, and also from a Ministry of Health perspective, in terms of what are they actually doing around public education campaigns and things, and how that all sort of fits together with general practice, really, whether you have any ideas about breaking through those barriers.
Yeah, well, but there's a whole lot of answers to that, really. I mean, the issue that the whole world's focusing on is what we call vaccine hesitancy at the moment. And the first thing to say for us as a country is anti-immunisation, the absolute anti-immunisation is not increasing. But you have pockets, like assume where you come from. So they tend to group together in community styles so that, you know, my picture of this dog here, the reason I like putting this dog up there is not because he's cute, but because Waiheke Island is really good at vaccinating its animals, but not so good at vaccinating its kids, which is really interesting, isn't it? So, you know, you've got community attitudes and pockets issues. So what can we do about that? Well, firstly, what we still know is despite all the social media and their community effect, that the one-on-one conversations with your frontline healthcare professionals are actually core to the whole issues. So if we start having doubts and if we get confused and concerned, that will raise the dissonance hugely. So the first thing is feel confident ourselves about the science, and then the second thing is it's about our individual communication abilities. So I do tend to look at communities and want to know what is the question. And you've got a small amount of people out there who are just anti-medicine in general until their kids get really sick. They say, you know, over my dead body. That's fine, but you've got a larger group of people out there who tend to talk the auntie across the fence and just hear a lot of issues and a lot of myths. So really the first thing is, what is the question that the people are particularly concerned about, and what is the question the community is particularly concerned about, and what is raising their fears, and really trying to hone in on the question. So it is about our communications and our ability to communicate and to hear what the question is, because it's not that these people are anti-immunisation, it's often that they've got fears and concerns and myths. So the number of people out there that still believe MMR is linked to autism is extraordinary. It's just got embedded in communities. And so in the end, I think it's going to come down to every one of us continuing to believe in our science and our general practice and communicating it. At the national level, I have to say there's not a lot of money going into the resources, but they are chipping away at it and really putting the responsibility on the DHBs to support. So if you need extra resources and support, it is meant to be at the DHB level now. This is a very limited answer to quite a complex question. I'm really happy to talk about it further later. Yeah. Oh, sorry, over here first. Yeah.
Nikki, sorry, how do we run out of a vaccine?
How do we run out of a
happen?
vaccine? That is such a good question. There's also a huge world shortage of IPV at the moment, which is just dreadful because we're on the home straight with polio eradication and we're going to have to use fractionated doses. How does it run out? Well, this is the complex issues about pharmaceutical industry internationally making vaccines. I mean, they're obviously quite a complex biological product to make, and it's not just the design of them, but it's the upscaling of the biological products. And pharmaceutical companies want to make a profit, so they plan ahead, they upscale, and if something tips over, it looks to me like they don't have enough backup to do something about it. So it's a really difficult issue we're talking about at the international level, trying to plan more effectively. And the other thing, the vaccines we run out of are not the ones that they're making large amounts of money out of. So, you know, we need more IPV, we need more BCG, we need more acellular pertussis, but the pharmaceutical industry often is driven towards some of the newer vaccines, which I'm not so impressed with. So some of it's just a mismatch, and, you know, you're in a private market. So it's a lot about that. You know, but certainly the WHO is trying to put more pressure at the international level on restoring volumes, but we've got a long way to go. Yeah, it's very depressing. Yeah.
My question is about health professionals, or two questions. One is how long is the vaccination for hepatitis B going to last in your nurse or yourself? You know, is there any time boost for that? And the second thing is, a lot of midwives direct access, so they're not nurses, and they bring in the anti-vaccine concepts, and so a lot of my patients who have been looked after by midwives have been almost advised, or the implication is they shouldn't have their vaccinations in the pregnancy. So they're missing out on the pertussis and flu shots.
Yeah, so the first one, hepatitis B, interestingly it's about cellular immunity. So once you've had a course of hepatitis B and you've had your serology measured and you've shown you've got a serological response, you need never worry again, okay? We've got pretty good international evidence now that once you've shown you've been immune Doesn't matter 10, 20, 30 years later. Don't recheck it, okay? The issue about midwives and anti-vaccination, we are actually putting a lot of effort in the antenatal arena, and interestingly, there is quite a lot of movement now. Now, there are still LMCs out there who are anti-vaccination, but I know there's a lot less than there were a few years ago. So one thing is communicating better, educating better in the antenatal arena. There's some other interesting blocks. Obstetricians don't even think about vaccines. So if people are going through private obstetricians, they often also miss out on their antenatal vaccines. And I think the thing is that the antenatal period has been a real headspace shift from like 10, 20 years ago when, you know, a pregnant woman was sacrosanct. You didn't put anything into her. You didn't give her a vaccine. You just left her alone to cope with her own flu and her own pertussis. Whereas in the last 5, 10 years, you know, the world is much more aware of the gains of antenatal vaccination. So I think our frontline healthcare providers haven't always caught up with the shift in our medical knowledge around the advances of vaccines antenatally. Now, as they are catching up, I think we're also beginning to see that they're becoming more supportive of the childhood vaccines as well. So it's a long, slow progress, but we're definitely making quite a lot of progress. At the same time, I think if there's individual LMCs out there, we can challenge them and go to their professional groups and saying, are you being backed up by, you know, your contracts are obliging you to promote these vaccines? You know, are you not evidence-based? I mean, there's a GP in Auckland who is not promoting vaccines. So it is out there everywhere. I think we just need to keep challenging our colleagues. You know, like, if you'd want to go against the science, then show us your evidence base. You know, we can challenge ourselves about this because, you know, childhood immunisation programs, you say to somebody, every country in the world has a childhood immunisation program. There is not a single country in the world that does not have a childhood immunisation program. That's an extraordinary world conspiracy if we've got it wrong, that every single country has it. You know, I mean, even in war-torn Yemen, there are frontline providers out there, you know, getting killed for delivering childhood vaccines. So when somebody comes and tells me there's something wrong overall with our strategy, well, that's an extraordinary conspiracy. Yeah, so I think we're getting there, but we've just got to keep up our own understanding of what we're doing. And it doesn't mean that all vaccines are safe and that we should use all vaccines, but we know and understand the vaccines we're using. Yeah. Yeah, down there.
In New Zealand, we don't have BCG. Some of my patients take the kids to overseas to have the vaccination. How do you advise them?
Okay, so firstly, BCG is not a brilliant vaccine, okay? So if you've had BCG vaccine is expected to reduce severe, widespread malarial TB, but it doesn't stop pulmonary TB. So firstly, there's not a huge gain in using BCG vaccine, which is why we only use it for really high-risk kids from high-risk families or countries. So for most of them, I'd be saying, are you sure you need the vaccine? And secondly, we give it neonatally. It's even less effective if you give it later. So unless they're travelling in pregnancy as in a neonate, the gains for having BCG later are not huge. It's not a great vaccine. I don't think we should be using it widespread. So on the whole, most people do not need it, would be my advice. And having said that, if you are in a family with high risk, like we've just talked about, and you can access the BCG vaccine for your neonate, go for it.
Hi, Nikki. Jan White. I'm a GP in Mount Eden. I wonder if you could just comment on Australia's idea to make it compulsory.
Yeah. No jab, no play. Yeah, it's really interesting, eh? So I think this is why I love general practice. You've got the tension between individual rights, which are really important, versus the rights of a community to keep itself safe. And obviously most of this is about the herd immunity argument. So that if an unvaccinated child goes to preschool, then there is the potential they can spread to others. And they can spread to infants who are too young to be vaccinated. They can spread to immunocompromised infants who may not have responded to vaccines and can't have live. And they can spread to children who's had the vaccines but haven't responded. So there's an argument from a societal protection as to why you should do it. Now, in Australia, politically, they went and targeted low-income people and decided that they would target low-income people. Now, most of those low-income people are not anti-vaccination. There's a whole lot of other barriers as to why they didn't vaccinate. So I think it was a very immature approach, that they weren't looking at the broader approach. Do we need to do it here in New Zealand? Well, quite frankly, I don't see the need, because you would get a huge kickback from people who think they have individual rights. So I think we'd be only using a strategy like that if we really thought it was needed. Now, we've got nearly 95% coverage now for our 2-year-olds, and we have got almost full closure of the equity gap. So we're vaccinating our Māori kids, we're vaccinating our kids from poverty, we're vaccinating our Pacifica kids, and we've got a small percentage we've not, although it is higher in some communities. But overall, New Zealand's doing bloody well. So why would we come across with an authoritarian mandatory policy when at this stage, I can't see why we need it. You know, we haven't got rampant disease running through our preschools. So I think from a science logic point of view, there doesn't seem any point in doing that. And, you know, I think you'd have to use mandation very carefully. And, you know, we've already got the right, if there's an outbreak in a preschool, to send the kids home now. So we've got legislation that's protecting us to some extent. So, yeah, there is the risk that unvaccinated kids are spreading disease to others, but it's relatively small in the current climate. That would be my answer.
Hi, Nikki.
Where am I looking?
I'm this way here. Sorry, to your left.
Oh.
Hi. I'm Jyoti. I'm a GP at Ellerslie Medical Centre. Just want to know your current recommendations for Minactra.
Minactra, yep. Yep, and there's 2 quadrivalent conjugate vaccines out there, so there's 2 of them available. So I think that in terms of meningococcal disease, New Zealand doesn't currently have it on the schedule. And the reason we don't have it on the schedule is, interestingly, overall, we've got quite low rates of disease. So the countries that introduced it, like the UK, had much higher rates of disease. So we do not have a meningococcal B vaccine available. There is an international one, and it may become available in New Zealand soon. But if people want a men's B vaccine, it is available in Australia and the UK. Now, in terms of using Minactra, ACY and W135, I think for infants in New Zealand, the most common disease is B and C. So if you want to protect infants, then I would suggest that the monovalent Cs are fine, okay? But if you want to protect people who are going to travel, where it's not just B and C, but there's also A and W135 and Y, then you might as well use a quadrivalent. So the quadrivalent vaccines are good, they're effective, you can use them in infancy, you can use them from 9 months upwards, and the 2 ages that are at highest risk of meningococcal disease are infants, toddlers, and then teenagers and young adults. So those are the 2 ages I think about for the private market, is that I offer and I recommend meningococcal vaccines to infants, toddlers, and then to mid-teenage years and to young adults, particularly those who are likely to group together as teenagers tend to do. So those going to university, those living in hostels, those in school hostels, I think there's a good place for it. So this is just my advice for people when they have to pay for it. Does that answer it? For a teenager, you tend to use a single dose, and then you'd probably have to boost within about 5 years if you still wanted further protection. In a younger infant, you have to boost in 3 years. Yeah.
Okay, I'm really sorry, but we're going to have to call a close to this. Can we thank Nikki very much for a wonderful presentation?